6, 8, in the 80s, yeah. And so we got to see how he counted it out there. But here, working with a clinic and working with UH, taking the kids downtown to meet patients and to sit in on, Jack Connery at the clinic was head of neurology at the time. Do I have that right? I think I do. And he asked our kids to come to Chief of Service Rounds, where all the doctors in his particular, he was a neurologist, all the doctors, and then they wheel in a patient, and he talked to his doctors about the situation. One guy who had AIDS, who said, yeah, I have AIDS and I'm going back and I'm going to be active, I'm not telling anybody, we can't do nothing about it. Other times when he did something that made 3 people faint in my class, but he insisted, as another doctor at UH did, that the kids participate with the doctors who were there for the rounds and ask questions as you guys are going to do. They're already laying for you. And participate. And so I don't know how long we did that class. Perhaps 8 years, 7 or 8 years. And for me, it was incredible because it was hands-on and it was face-to-face.
I think the start of the public consciousness and the change or the examination of journalism approach was probably generated by the Karen Quinlan case, because that focused America's attention on the right to die.
What year was that?
That was the late 70s.
Yeah, late 70s.
So that was what the Karen Quinlan case, that was what it was
So right
before.
down. Yeah. So, ladies and gentlemen, Dr. Baron Lerner, class of 78. Where do I sit there? You can sit in the front or you can sit.
Anyway, very pleased to be here. Thank you, Peter. He and I have been talking about trying to get me to do this for a long time, and I'm so glad it worked out. Little nostalgia first. So I was trying to think the last time I was in these buildings. I haven't been back to the lower school at all. So and I wandered in the wrong entrance, and I'm like, I don't recognize this at all. And I started walking in, and I found the chapel. Oh yes, where I didn't sing. It got in trouble. The Jewish kids were singing, and one or two kids somewhere singing. This was a very different year at home. But it was just fun to wander back. Actually, on the way out, we're going to go look at the photos of all my old professors there, with all my old teachers, which is very cool. So that's great. And then it's great just to get to do this with Peter, who was my upper school English teacher, and to the degree that I'm a good writer, he certainly is one of several people who can take responsibility for that. This talk was amazing. The English department in particular was a remarkable place to learn about. So, again, another great so anyway, I'll talk for a little bit, but the old saw, of course, is you can't make it with like undergrads and med students. You can't make people read something and then not talk about it. That's what we're always told. So I do want to wend back to those things because I'd love to hear what people think. I obviously picked a smattering of stuff. The two articles obviously build on the book about my dad and me and medicine. So maybe we'll start there in a little while. But I'd love to hear what people thought about the Oliver Sacks piece, and then maybe finish with the New Yorker stuff, only because it's particularly relevant today. I don't know if people heard that Jerry Brown signed the law allowing assisted dying in California today.
Really?
Yeah. So that it's just a very interesting trend, obviously, not what's going on in Belgium, thank God, but this interesting way of reasserting autonomy, as it were. So I'll talk for a few minutes, and then we'll just try to, and if anyone wants to interrupt right away, just go ahead, very quickly. So my introduction to, it was interesting to hear when you guys started bioethics in the mid-'80s. It wasn't very much after my first class of bioethics, which was my first year in medical school in 1982. So Kieran and Quinlan case was mid-'70s. The other thing that people will always talk about is the Tuskegee scandal in the early 1970s. And eventually building to, by the early 80s, when I was at Columbia for med school, and the medical school said, gee, we really need to start to teach this bioethics thing. And it was interesting because, how would a very conservative medical school teach bioethics? They didn't want anybody to completely upset the apple cart. So they went and got a history professor from the main campus of Columbia to come up, because he'd written about the history of mental institutions, which made him, which automatically made him a historian of medicine and a bioethicist. In those days, now you have to get credentialed, but he sort of got grandfathered into it. And that's how I sort of got into both history of medicine and bioethics. I got very interested. And so as a first-year medical student, when my classmates were burrowed in their books, learning about biochemistry, anatomy, and physiology, I was feeling very restless. College, and I enjoyed that, but it wasn't enough for me. So when I met this professor who was teaching, a historian who was teaching bioethics, I was hooked. And did research for him over the summer and all that stuff that you do if you're very, very interested. And eventually sort of wended my way and was able to be both a practicing doctor and to teach and to write about bioethics and history. But that class was interesting because many of the tensions that we'll talk about tonight were brewing in that class. And the question really was basically that doctors up until that time, really until the 70s, ruled the roost, one of whom was my dad, and were rarely questioned and made decisions for patients. And the stuff you read doesn't have some of his other hijinks in there, which was not just him, but other doctors of his era in the 50s and 60s in particular, routinely manipulating information from patients and telling patients one thing, telling families the other thing, not concealing diagnoses, very common in medicine at that time. But it was all done because they were paternalists. They knew best. Let us shoulder the burden of the bad diagnoses and let us tell you what to do. You don't have to do homework. Just put your hands in us. And it was reassuring, and the doctors were devoted, and I mean, my book is actually full of stories of doctors working 24 hours a day, 7 days a week, not just my dad, but other doctors. But there was something wrong. The society was changing. And, you know, you think in this country, the civil rights movement in the 1960s, questioning race relations, Vietnam War protests, questioning military, feminism, questioning male domination society, all of those social changes, and boom, it comes to medicine too. So, and we've already mentioned a couple of them. So, research scandals, not just Tuskegee, but other scandals where doctors had entered patients into studies without informed consent. And the Karen Quinlan case, where doctors seemingly were deciding who lived and who died, and the interests of the parents didn't seem to take hold. And something I alluded to in one of the articles, which was going on absolutely in hospitals at the time, which is that doctors basically were talking amongst themselves when an ill person would come into the hospital, there was a chance they were going to not make it. Was there going to be resuscitation or not? And the doctors on rounds would basically do this or that, and they would, at one hospital in New York in particular, where they got in trouble, they used to take little stickers, purple stickers for some reason, stick them in the chart if it was like, don't do anything. And then when the patient died, they'd quietly pull the sticker off and put it in the garbage. Okay.
Were DNRs available at the time?
No. So that's a perfect segue.
When I was in law school, I drafted a bill,
Okay.
which was for the right to die, to have a living will. This was back in the 80s.
Okay.
And I got a senator from New York. This was state legislature in New York passed it. And that went around the country where we got one step where people now execute
Yes.
wills. So you might not want, you know, artificial feeding, whatever,
Yeah.
et cetera, et cetera.
Yeah. So
that was the incremental start.
exactly. It was a time of great ferment. So there, right. So early on, people started living wills was the first iteration of that, which is, and it really built on the Karen Quinlan case. It was basically like, if I ever get like that, don't do this or that, right? It was basically that sort of thing. But things became more sophisticated, and the first do not resuscitate law was in New York State in 1980. And built on the first DNR law, where it's actually a law, in New York State, 1988, and it built directly on a case that stemmed from the secret stickers, because they basically, it's sort of it's a little amusing in retrospect, that one patient at New York Hospital, 1984 or 5, congestive heart failure in his 80s, and the doctors say, okay, if his heart stops, we're not going to start it again. Turns out his grandson was a doctor and was at the bedside when it happened. So he dies, and no one runs into the room and starts doing it. And long story short, he makes some inquiries, goes to the media, and they say the doctor's playing life and death. And eventually it filters up through the legislature in New York, and they pass the first DNR law saying family, the patient or family gets this. So, and later we get healthcare proxies, which is a better version of living well, I think, where basically you designate someone else. So it was a time of great ferment. And looking back at my own training in bioethics, certainly at the time, it was very focused on patient autonomy and patient's rights. And so as I look back as a historian, I think there was such a revolt against what went on in the paternalism era that the pendulum sort of had to swing in the other direction to a very fierce patients' rights type of movement, where patients got to decide, doctors were eliminated, from this. Doctors were supposed to just give options to patients and families, things like that. And now I think the pendulum has swung back a little bit because for reasons I think that, and hopefully we can start to talk about the articles a little bit, for reasons that things that happened in hospitals, maybe it didn't make so much sense for patients and families to be making all these decisions, right? I mean, I certainly have patients who come to me all the time, and it's like, what would you do, doctor? Actually, it's funny to some degree, medical students get patient autonomy and informed consent pounded into their heads so much, including by people like me. But it's patients decide, and don't be like those old doctors who did these things. So they're so afraid. So when the residents, I'm an internist, and when they present cases to me, sometimes they'll come in and they'll present the case and they'll say, the patient said to me, what do you think I should do, doctor? Right? And they're all like, I didn't say anything. Right? They're all like, and that's when we have a little mini lecture on bioethics, and I'd say, it's actually okay to answer that question. And you need to tell them their decision shouldn't be based on whether or not what the doctor wants. But it's okay. I mean, that's a fair question, and it's not an unreasonable question, right? You're trying to get people with expertise, people you're trusted, people you've bonded with over time to give you advice, right? So I think we're sort of in the middle there.
So in the old system, someone would give you advice, but now they sort of say, well, you're on your own. And even you're given your choices, and the surgeon will say one thing, and the oncologist will say something else, and then you go home, or the patient goes home, and they have to sort of make a choice.
Yeah.
And so I'm not sure that's so much better.
Yeah, exactly. I think I think it's an ongoing struggle. And, I think it depends on what the issue is to some degree. Who the patient is, who the doctor is, whether there's a long-standing relationship. But yeah, that's the exact tension. I think, we're reluctant at times to be too directive because of this past history. But I think patients at times are, or because of litigation, right? Both. And yet, people are always sort of asking and trying to do that. Because it's a very hard thing.
Because you guys are the experts.
Right.
So it would be normal to say,
It would be normal.
What do you think I should do?
Right. And the old, at ethics conferences, someone always, eventually raises their hand and says, when my plumber comes, he doesn't give me 5 choices.
Right.
He tells me what to do with my car. I need doctors. What are you doing here? And, the
It
answer,
is fitting.
the
Well,
answer
there's a
is
caveat to
please.
that. Max Trottercott spoke to. I'm participating in a concussion study.
Mhm.
I've actually had 3 that I can recall, which means that there are more
Okay.
that I can't.
Yes.
And ethically, from that standpoint, from that mentality, I can recall going back into several lacrosse games.
Right.
And what we said was, you got your bell rung, or you got dinged.
Yeah.
And it was a badge of honor. It was a staple of pride. In fact, at 80%, 75%, I felt stronger than the second string, third string person who would replace me.
Yeah.
I have actually, through the study, found that there are numerous symptoms: memory loss, retention, emotional, mental health issues, as well as physical issues regarding, I don't want to pop my knee, but, I've taken some pretty significant damage. It's gonna carry through the rest of my life to the point where I don't want my kids playing contact sports. And that science has come so far in the past 5-10 years. We almost study a broken leg more than we study the thin layer of fluid that covers the brain and the oscillation back and forth
Yeah.
That's
between
because
it.
there's too much money. Concussions, way too much money.
Well, the human brain is.
No, you've got pro sports, which is a
Yes,
multi-billion
ma'am.
dollar.
I wouldn't even want my kids playing soccer, because when I study the header element of that game, it is probably the most dangerous. Helmets have come so far, but that game is almost brutal. I boxed, I wrestled, some of you know that. some of your sons actually wrestled against me. I feel for them. But, elaborate on that.
No, it's very interesting, and just to think about it from the doctor perspective, this is, was there a I'm literally asking, well, who was in charge of deciding whether or not you went back in at the time?
Well, there's a study now, and it's come over the past 5 years. You actually are tested to walk a straight line, but I can recall being in a game and almost getting Sonic the Hedgehog. I got rolled by a man almost 150 pounds larger than me. And all I could think about was, what was his number, and getting back in.
Yeah. It's you going to comment on that?
Yeah.
Please.
The interesting thing is that a lot of people feel like you don't want
Peter, your background, your experience.
a little bit. Yes. But a lot of parents don't want their kids to play football at the youth level, but actually at the youth level, there's more head injuries in soccer than there's tennis.
Yeah, this
It's
is
not safer. There might be less injuries, right?
Yeah.
I don't know what precipitated that, it's only within the last 10, 8, 5 years where this,
Well, I would say it's funny. One of my people might even know the name Art Kaplan. Anyone who does ethics, he's sort of like the talking head of the world of ethics, who's now my colleague at NYU, very good guy. And he started a sports and ethics institute at NYU. And they're looking right at these things. And part of what I've learned from him is that for years and years, just like the medical profession wanted to be in charge for years and wasn't really questioned, the sports establishment didn't want issues like this coming to the surface because, and not necessarily evil, but just, people wanted, athletes wanted to play, teams wanted to win, doctors associated with teams wanted to be good guys and stay the team doctors, and quite frankly, I remember stories about this in the 1990s. Doctors felt very uncomfortable if they were the team doctors saying, he's out. Because the team, what do you mean? He's got to go back in. And I remember I knew a couple doctors who quit their jobs because they couldn't deal with it anymore.
there's an app for that now. I just saw
Oh, really?
it yesterday. It's a guy, Russell, here in Cleveland,
Okay.
some physician who made an app
Cut for concussion.
for concussions and
Yeah.
sports injuries, so the coaches and the physical therapists on the sidelines can put in the symptoms, boom, and you go in or you stay out.
Yeah. No, it's good. That's, to the degree that's science coming in, absolutely.
That's one of the basis for all the retired players, once we got together to sue the NFL.
Yes.
Which is another very
Yes.
differently
Yeah.
hit
Yeah.
the effects of professionals.
Yes.
Most professional athletes, if they have an injury, they would never go get operated by the team doctor, because the team doctor works the team. They want to make that happen.
It's quite frankly, it was conflict. It was another ethical issue, conflict of interest. And it's funny. My daughter used to play soccer, and I, being a doctor and seeing these things, it was a couple girls on the team had it all. My daughter was afraid to have it. That's why she doesn't. She was very good. But there were girls on the team who were like beasts, and you kept thinking to yourself,
Also, I just have one more. The standing 8 count in boxing. It's almost
There's no science behind that.
it's
right?
you're a categorical
Yeah.
coward if you don't
Yeah.
get back on your feet in
Yeah.
that period of time and continue to do battle.
No, look, one thing that can unify some of these themes is what we're putting these things as science, right? A lot of this, for years and years was, in the world of medicine, was, I'm an expert at this, I've seen this, I know what to do, right? Similar in the world of sports, and, to the degree that you can actually do studies. And to come to relate to the article, one of the articles that I had you guys read, some of what my father was up to as an infectious diseases doctor was he was just disturbed at the fact that all of these patients who were very, very sick and never getting better and getting worse, were coming in the hospital with infection after infection, and he was the one keeping them alive and then sending them back to the nursing home. So he was saying, you know, what tradition has been isn't right anymore. But, you know, but he met with a lot of resistance too. And, you know, why did people want to bring people back into the hospital? Well, you know, it made money for the hospital. It was easier to not have to bring up these uncomfortable topics, whether it's your loved one is dying or whether you have a concussion problem. And, you know, at least now, I mean, there's progress, right? These things are front and center, if for no other reason than the internet, please.
I'm just wondering now today, are they front and center? Because we went from, you know, your father's generation, this paternalistic approach to autonomous, and now you say we swung back into kind of a balance. And I don't know how it is in New York, but in Cleveland, Ohio, with our healthcare system, and I think it's probably national, I don't know, but I don't know that I could rely on my primary care, my family physician for advice, because Cleveland Clinic and UH are like factories.
Yeah.
They don't know me at all. And I don't know, I think part of caring for patients and giving advice as to treatment and good prognosis and that kind of thing is knowing emotionally, not just physically. And these doctors today don't know any of their patients. Family members, they couldn't say, well, I think that, you know, the suffering would be too much for you. And you were, like, they're strangers to us. And I think that puts it back into patients making their own decisions without, not only without expert advice, without personal and expert advice, but without
Knowledge.
The internet is now
right, but I want to say expertise, because part of their expertise is to know their patient's history, how they responded to certain treatments, how they had it. And now it's just like, honestly, I trust my own opinion as to my care and treatment more than any one of my doctors.
Do you want to build on that?
Yeah, I'm a neonatologist, so I take care of premature and sick babies and do place decisions all the time. And I'm old enough to remember when I first started, some of my older colleagues said, your baby's going to die, and then watching them turn their reaction to the baby die.
Right.
But I'm also young enough to have lived through this era, and it's gotten to the point now where we have families that you know this baby's going to die, and we're trying to, with whole resuscitation, I mean, newborn break ribs, long coma, it's painful. The baby's been on a ventilator for 2 months, and you know that it's going to die. And the family says, if God wants the baby to die, God will take the baby. And that keeps suffering. And you're trying to tell them this, and they say, no, we want everything done. And that's equally painful.
I think
Not more.
I think it's the time of technology. I mean, Bill Moore's had a big special and said the human body wasn't meant to live as long as we are now alive. This is the advancement in pharmacology, technology, etc. So that's where the real crux is. Doctors say, well, if we have another drug or we have another invasive procedure that might have a 1%, we're going to do it. And the human body wasn't meant to live that long. And
I think it depends on, you know, what the patient has or what the condition of the patient is. And I think some patients, because of the length of their illness, do have a relationship with the physician. So in oncology, hematology, there would be a relationship.
I think that when you have a chronic condition or a relapsing condition that isn't cancer or isn't, you know, a brain aneurysm or isn't congenital heart failure, where you are some specialists, and even at that specialist, you sometimes see a specialist in the same office, but not necessarily one doctor at a time, but it's, you know, sometimes Crohn's disease, and it's going to be his whole life, and it's going to be treated, and yet there is that treatment, you know, there needs to be a time and space where you see a patient to weigh options when they're in a crisis versus when they're not in a crisis, when they're having bad reactions to drugs that are supposed to help, but they're harming it. There's not that time. I mean, like the doctor, and he's very, I love him to death. I mean, I personally as a gastroenterologist, let's say, but like you're not looking at him, you're not seeing whether how he's reacting to that thing, because a lot of them even on the phone. You call, they don't even have time to see him to adjust the medication or to actually talk to him to see how he's responding.
You think doctors have too short office visits now?
Too short
Office visits. So
Of course they do. They're on a
which unfortunately, none of them are in control of the office at the time. So that's great.
That's, yeah, but it's.
Dr. Lerner,
Right,
who's dictating all of this? The doctors, the insurance companies, or the pharmaceutical companies?
All of the above.
Administrators.
Speaking to well, there's lots of issues floating around here. So, you know, I would try to pull something together. So, you know, I think absolutely what is missing from many doctor-patient relationships is the ongoing time. The one thing everyone can agree on is the time thing is bad news. So, you know, I have to see a patient every 20 minutes. I'm secretly
Who says that? Who says that?
Bellevue Hospital, Health and Hospital Corporation. That's administrative. I'm secretly pleased if a patient doesn't show up, because then I can spend more time with the ones
But
who
that's
show
my
up.
question.
Okay, it's complicated. Look, insurance, it's reimbursements. I mean, that's the main driving factor. So Bellevue Hospital, they want us to see every 15 or 20 minutes because no one's getting paid unless you're seeing a patient. So that's the driving force. And, you know, how are you going to fix it, right? Now, there's some mitigating circumstances. So ironically, if you get a condition and, you know, cancer is mentioned, Crohn's disease, you can at least potentially build up a relationship over time with people. And I will tell you, I mean, I teach this, so I focus on it. So, like, I try at the end of the 20 minutes, at the 15-minute mark, to say, you told me about your back pain 25 times. I don't want to hear about it. What else is going on? How are your kids? How are your parents? Blah, blah, blah. And then I write them in. And, you know, if I see someone 2 or 3 times a year, maybe something else is a little emergency, I put something in. Sometimes, not infrequently, the topic is someone else who's sick in the family. And I'm like, this is helpful. Partly because I can maybe give some advice, but also I do my little scribbles. And I say, sister in hospital with cancer. And I'm like, what do you think about that? Think blah, blah, blah. And I put it down. It's not what my dad could do, which was go in the middle of the day and sit on the patient's bed and take their hand and say, sit there. But it's something. And I will say that to the degree, I think doctors have a duty, despite their schedules, particularly primary care doctors, to try to do stuff like that. I'm not saying my system is better or worse or anything. But I think there's a duty to try to do that, because otherwise you're just doing the cookbook doctoring. And you know, for some things, cookbook doctoring is okay, right? I love to show that, if you want to go watch it, people remember this movie from the early 1990s, The Doctor with William Hurt. I mean, it's the best teaching movie ever. Like, you just put it on the Netflix, like all crazy. You just start talking. But there's a great scene in there where William Hurt plays a surgeon who gets cancer. So it's totally hokey. But at the beginning, he's like sort of this, you know, macho surgeon, and at one point he says a great line. He's like, if there's like 30 seconds to get in there and start cutting, I want a surgeon who's going to cut and could care less, right? Just that sort of thing. And so there are certain instances where you want that sort of person, but it's disappointing for most practices of medicine that we've come to a point where the doctors themselves sometimes don't feel that's a part of their job, right? So I hear what people are saying about that, and I tell people to push back. I say to people, if you're dissatisfied with that, in a polite way, just say, I feel like all you're doing is throwing out options for me, and I realize you're busy right now, but could we have a talk about this at another time? I mean, if you're being like a good consumer or something, right? Which seems like I hate when people use client and consumer in medicine, but ironically, and when my patients come in with a stack of stuff on the internet, my first reaction is like, oh. But then I'm like, oh, take a deep breath, and sometimes I have to say, okay, like you have this, pick off the 3 pages you want to look at that are most important. And sometimes I look at them and I say, you know what? I don't have time for this now, but I'm going to look at it. And I'm going to, it's like, should I take, the latest is like Bioethics and coenzyme Q, and what do the studies show? And I'm like, I sort of know, but I don't really know. So then I'll go back, and before that, I see them the next time I've done the research. You know what? And and on a Saturday or Sunday, when I'm, instead of watching the Browns lose, I can just go on and do like 10 internet searches and make 10 patients very happy. And that's why I try to teach students to do.
So, I want to think about topics. There was a article in my conference. There are people that look at that company. It's not the highest standard. But it was an interesting story about a doctor who fired their patient. The patient decided to send a letter to the media, which they then published. That's right. And why did well, of course, the doctor wouldn't disclose, the patient wouldn't disclose. There could be a business issue, literally. They never showed up for a point. Okay. So it could be totally different, but the presumption was that the patient wasn't following care prescribed by the physician. The physician just said, I'm not the right doctor for you. Yeah. You need to find another doctor. But what are the ethics around firing a patient?
Yeah, it's interesting. If you look at ethics guidelines, you're never, they would use the word fire, but you have a duty to your patient. The standard teaching would be if you could find another doctor for your patient, it's okay to do that. So to the degree that this guy said take a hike, it was probably on dicey ethical grounds, although, you can play it back in various ways where, sometimes the patients were abusive and really inappropriate, and at that point you can build more of an argument along the lines of doing that. But technically speaking, the word that's used in ethics is abandon. You may not abandon your patients.
This is almost like 30 days.
Well, right. I mean, that's another huge issue. So So, but I think as a doctor there, you would have a duty. And it's easier for me because I work in a hospital with other doctors, and we sometimes transfer difficult patients amongst ourselves. So all right, I have to take a story. I got a patient about 3 years ago who was being followed by another doctor in the clinic who's a totally good doctor, and this guy comes into me, and he has a psychiatric history, but he comes in, he's like, everyone recommended you, and this other doctor did this, and reported me, and did all these things, and you're such a good doctor, and you're like, you listen to me and all this stuff. So I'm like, this is like a disaster waiting to happen. But there was a honeymoon period, and I tried to do my best. And I feel like I can work with difficult patients pretty well because I have experience, and I use humor and I'm disarming, but everything I did was wrong with this guy. I just couldn't, whatever skill set I had. And so, I don't know, about 4 months ago, I saw him and he announced, this will be my last visit with you. He's like, I don't want you to be my doctor anymore. And I was, so I raised the topic and I said, okay, I understand, blah, 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 what do you want to talk about, this and that. And I said, it's important you get another doctor. He said, no, I have Dr. So-and-so, he's my new doctor, he's one of my colleagues. So he found this guy in some way. So anyway, long story short, I run into my colleague doctor after he sees him, and he comes up to me and says, "Oh, do you know Mr. So-and-so?" And I'm like, "Oh, yes." And he's like, "Oh, he's my patient now." And I said, he's like, putting in a nice light. And I said, "He'll love you for like a year, and then you're getting fired for this." But the point was that I did want, no matter how tricky it was, I think there was a duty to say, part of this guy's problems are psychiatric, right? So my patient leaves, and there's a duty to say that you will continue to work with them in some way, even if you're not going to do that.
So I would think with this consumerization,
Yes.
that would be more frequent.
Yes, and look at although these days I think part of the reason that people are dissatisfied with their doctors, they're going to go to another doctor and say the same thing, right? That the office staff isn't solicitous enough, that their visits are too short, that the bill that they're getting their co-pays are too big, or whatever it is. Yeah, I mean, it's very common. Please.
So everyone here can give you an example of a hassle that they've had or as a practitioner, challenging cases that they've had. But how do you address bioethics when you're teaching? Where do you start? How do you deal with it? I mean, that's really what I want. That's really what I want to find out.
Okay.
Because it's just too big.
Yeah, anything specific?
I mean, how do you teach a course when everybody in this room can give you an example of an issue that they've dealt with? And I'm sure when you're teaching, everybody has that issue. So how do you teach them?
Well, I do. It's very setting specific. So I teach it to undergrads, and I teach it to med school students, and I teach it to residents. It's very often helpful to use cases because you're drawing in, for the students in particular, cases are very good because they relate to them as stories. So that's very, very important. I like, if possible, to bring patients in. So I have a patient who is a 6'8" jazz musician who is cantankerous as hell, and he had an incident where he's diabetic and he doesn't take care of himself well enough, and he got a infection of his osteomyelitis, and I sent him to our podiatrist, and they told him that he needed an amputation, and he refused, and he went to another doctor on the outside who said, "No, you don't need one." And long story short, he went and he was fine with antibiotics. And he came into me and said, "Your colleagues are terrible and horrible." And I said, I'm glad you did what you did, and I'm like very impressed. Let's make this constructive. I said, "How would you like to come and talk to medical?" I'd like that a lot. And I was like a little nervous because this guy, he's like a live wire. But I brought him in, and the students loved it. Because he was like, and he toned it down for the students. But I said, here's someone who came in and said that we were trying to do surgery on him that he didn't need, and he saved himself an amputation. How do we deal with that, and how do we learn from that sort of case? And that was, a patient asserting his rights. But then I contrast that and say, at the end of the session, I say, and he even says it a little bit, because the student will invariably ask, "Okay, how do you guys get along? Because I take care of him for everything else." And they're like, "Do you never listen to Dr. Lerner?" And he'll eventually sort of roll his eyes and say, "Well, we bicker back and forth, but usually listen to him." And it's very instructive, right? Because there's a dynamic there where we're doing that. So doing that is good. The only other thing I'd say is as much as I can, and I can do this with my undergrads because they take a class in history and bioethics, I teach the history. So they love the old stories, and I tell them the stories of the paternalistic doctors, not just my dad, but the doctors who just did everything, and then how they got in trouble for doing that, and how it's hard to not want to tell your patients what to do all the time. We all want to do that, and yet you can't do that. You've got to be a good listener, and so I wind up saying often that bioethics is a lot of negotiation and listening, not so much. hear about these stories because they make it to the media of these, life and death stories, but a lot of it is interpersonal skills and trust and things like that. So.
I read your articles, and
Yes.
to take it back there, and it's on this subject actually.
Yes.
I guess I wanted to know your feelings on, there's one of the last things that you said in the Should Doctors Take Care of Their Relatives? You quoted your father right at the very end of the article, which, let's see, it just said in justifying his desire to get Donald more aggressive, my dad wrote, I am most concerned that his suffering end as soon as possible so we can remember him as he was. The Donald all knew and loved so much, not the Donald who suffered so at the end. And how much of the decision making that doctors made then, which I know is very different than today, and the advice that doctors give to their patients as far as care, is really like a codependence of sorts. Like, was it really about Donald and his personal suffering, or was it really about the doctor who had to see the suffering every single day and did, about his feelings about suffering, about his feelings of being the hero, about not wanting to make people go through this versus, like, what is, we want to remember him as the Donald as he was, or was it he wants to remember the Donald that he was?
Well, that's a good one. Since my dad never saw a therapist in his whole life, we don't know what his not surprising.
By virtue of being a doctor who is a natural caretaker, that is part of his.
I think it's a fair question. I think, I don't know. I think it's probably both. I think that, especially in the old days, and we can debate this now, in the old days, a lot of people went into medicine because they were just passionate about their craft, and part of it was telling people what to do, but part of it again was guiding people and being in charge and taking the responsibility away from people.
Well, I mean, that's the definition of being paternal.
Yes, right, exactly. Yeah, so I think that was part of it, but there was also but the thing that made my dad so effective was that there was that part of him, but there was also the objective part of him that was able to sort of change and see what was happening in medicine and that things were happening. Another thing I mentioned in the book, just a minor point, but feeding tubes. So people were putting feeding tubes routinely into nursing home patients who had dementia, cancer, end-stage strokes, everything. And now it's done less because now there's data. But like my dad, again, was taking care of people like this. And he didn't know anything about feeding tubes. He just realized that that what was happening from these feeding tubes was that people were going back and being put into a situation that he thought was not a way to live. And so there was an element of his own disgust and horror and misery at the situation, but it reflected, I think, the reality. And then part of the challenge for him was, and to talk about, the stuff that went on with my grandmothers, there I argued across the line, right? Where it became, to some degree too much about him. And that he wanted to do what he thought was right, that the rules didn't apply. And there's a reason there's rules, right? Because lots of smart people, and here's another funny thing. So after my dad sort of retired, he wasn't in patients anymore, he would go to Case Western Reserve to the Bioethics and hang out there, and he'd go to all the conferences. And I knew the people, I knew them professionally, the people who worked there. And they didn't figure out it was my dad until later on. But eventually they figured out, oh my, your dad? And what they basically said to me was, you know, your dad loved your dad. He'd come to all the conferences, and there'd be all these ethicists who'd come up and they'd talk about justice and autonomy and all these principles, and they'd be there, and he'd very patiently sit through the whole presentation, and then right at the end, he'd like raise his hand and he'd play doctor, right? And he'd be like, okay, I understand that, but let me tell you this. When someone's dying, or when someone's in pain, and it was a little unfair because he was playing the doctor card too much, but that's what drove him, right? It was the need to be personal and to let his feelings out, and that's again what so many of you identified today.
And we don't have.
We're afraid to do it. We're afraid to do it. We just want to get. It's easier for us to give a bunch of options and things, right? And do that, and we're afraid to say what we think sometimes because of legal issues, because we think it's unethical, things like that, and that's a shame. And that's another thing coming up. What I'm trying to teach now is how do you balance respect for people in decision making with being a doctor who cares about them and tries to learn about them and gives them some advice at the same time. It's hard.
Dr. Lerner, I had a very good friend who at the age of 97 decided that she really didn't have very much to live for in life. She wasn't sick. She couldn't see. She had macular degeneration. She couldn't hear very well. She couldn't walk. She had no children, and her nieces and nephews did not live anywhere near her. She lived in the Virgin Islands. And after a 3-year research and struggle, she finally decided that she was going to go to Switzerland, and she was going to take her own life over there.
Such a good segue to the topic I want to cover. Yes, go ahead.
Is there, I think I know the answer to this without even asking it, there's no organization or any movement such as that in this country.
Oh, the Hemlock Society. Although they have a different name now. They don't
Compassionate choices.
Dignity. Choice isn't dying, I believe is there. Choice isn't dying. There are many.
But you have to be sick. She wasn't sick.
You don't have to be sick according to
Really?
Yes. Well, first thing, if you do it yourself, you can do whatever you want. Whether you get a doctor to help you or not, and you know, this brings us to what I did want to talk about before we finish, was, you know, what happened in California in that article that I read, that I had you read about what's going on in Europe, which I think is extraordinarily extreme and worrisome. But there's an argument to be made, that would be called rational suicide. So there's been a stream of thought for many years saying that even if you're not sick according to our, you know, that you're not dying of cancer or neurological disease, that you have the right, and this builds to some degree on patient autonomy, that you have the right, and maybe you have the right to get doctors to help you to do this. So we've moved a little bit in that direction in this country, right? With physician-assisted dying, where if you, now that person wouldn't qualify, but it would be someone who has a terminal disease in this country, who, well, yes, remote physical, yes. Terminal disease, and basically there's a whole series of hoops you have to jump through, but if you get a doctor nearness in one of the 5 states that allow this, they can write you prescriptions that you can take when and if the time comes that you're supposed to take yourself. So part of the reason that this exists is there's always been people doing it on the sly themselves, sometimes with their doctor's help, sometimes not, which doesn't seem like a good thing, right? Because why should you have to go on living in it? Because we talk about patients' rights and patient autonomy all the time. Why is it that when it comes to the issue of dying, that gets thrown out the window, right? This is the argument. You know, you can demand to be on a ventilator, you can demand to get a transplant when you shouldn't be to have one, but you can't ask for help in ending your life when it seems reasonable. So we've been extraordinarily conservative in this country about that for good reason, I think. And we've opened the door a little bit. So we've come up with this compromise. And the Supreme Court has ruled on this, which there is no constitutional right to die. However, states can pass their own laws. So now 5 states have passed the law. So someone like your friend now could have, instead of going to Switzerland, could have gone to Washington and conceivably gotten a doctor there, maybe to help if she concocted enough medical conditions that she said, "I'll be convinced that she would have done." What did she go to Switzerland?
Yeah, she did.
And they helped her.
She went to an organization called Dignitas, I believe.
Okay, yeah, right.
And
Yeah.
as I understand it, as long as she was capable of holding a cup that had the medicine in it, and she was supervised.
Right.
That was it.
And that's how she got it.
Yes.
I empathize with that. Actually, my sergeant was in the Marine Corps. He's the man I credit with saving my life. And he knew that if he left our unit and went back to 1st Marine Corps Division, 1st MP Company, and was Force Recon Marine, he would eventually have a high probability of being hit by an IED. Or that he would ride in a Hummer, and that scenario was prevalent and relevant to his life. And he was much younger than the woman you're describing, but he was aware of the scenario that was present and was miserable and depressed in the current state. He was with my unit, which would have elevated his rank, but would have alienated him from the men and women in harm's way that he was credited for becoming a sergeant. And it means a lot. I would have to describe the blood stripe in the Marine Corps and actually what the history and the tradition of the Marines are and the fighting spirit of it, but he knew where he was going. And he didn't say it to me, but I remember being in the head, which is the shower, and he was terrified of me because he was trying to get the shower to stop dripping, and he was just frustrated with life, and the faucet was leaking. And I saw this scenario, so I grabbed the broom handle off now we weren't close by any means at the time, but I grabbed the broom handle off the wall, and I'm walking towards him. I'm sure he thought I was going to assault him because we had odds. And I saw that it was a rotating shower handle, and I hit it on the torque angle where with 2 strikes, it stopped the faucet for me. He said to me, he looked at the faucet, it stopped dripping. He looked at me and he said, "Adapt and overcome." And those were the last words he said.
He said what?
He said, "Adapt and overcome," which is a Marine Corps
So
accident.
what happened?
He left the next week. He actually dropped on request, DOR'd from our unit, and went back, busted himself down to Force Recon so that he could be with the Hummers that were in Operation Red.
Right. And where's he now?
He's dead. And I didn't find that out. Actually,
He died in the city.
he died in the time
Yeah.
he was killed in action.
It's funny because I mean, I'm glad you mentioned that in the sense of, and that's obviously an extraordinary circumstance because the military and stuff, but the concerning trend in Europe, and that this is hot stuff, is mental illness. And if there was anything, one was taught in medical school about a depressed person or someone with psychiatric illness, that was the one place you could override autonomy still, right? It was, we were respecting all of everybody's wishes, maybe to too much of an extreme, but if someone was suicidal or depressed, you got, at least for a while, you got to do whatever you want to them to save their life. And that's why it's so striking and disturbing, I think, to read an article like the New Yorker piece, where in many countries in Europe, Belgium and the Netherlands in particular, people who have mental illness and are tired of life are able now to get doctors not only to give them pills, but to actually administer euthanasia.
I'm not sure I agree with it all. Why it was a distinction.
Well,
This color, but I mean, I understand what you're saying, but presumably they'll come through the spell of depression, they'll say, "Oh no, I have nothing to live for, thank God my doctor didn't help me." But on the other hand, we certainly see plenty of people who are clinically depressed and taking their own lives.
yes.
So suffering emotionally.
Right.
Well, that's the argument. So that's the argument, right? So
It's not very effective.
We have very effective treatments. At the surface of what we're actually, we have very effective.
Right, but
Well,
people-
for example,
I don't think I do, but, then, I don't know.
did not take all of the theirs.
And she didn't even get
It's not
ECT.
good.
Right, she didn't get ECT.
But
So,
they made a point that the psychological help in Belgium is like not
Right.
very good.
yes,
So
which
it's always
makes it, and it's not good enough here either.
But you
But,
see, that's personal economy, it's not patient economy. I mean, the fundamental question is who has the right to terminate one's life? Is it the state, i.e. doctors? and
Right.
nurses, or is it the individual?
Yes, okay, so-
Whether it's mental
right.
or it's.
well, okay, but,
In
you
a way.
know, anyway, but clearly what's gone on there is that, again, to use a pendulum metaphor, you know, now the state, which, you know, has never been in this business before, you know, is doing it. So anyway, I wanted to.
that one doctor that's like,
No, I mean,
he's
it's
just
way
like,
out of control, yeah, and
he's like a monster.
but I would tell you that just as a last point, you know, with the aging of the population and disturbingly with concerns about healthcare availability at the end of life, and some of these are driven by people who want to not burden their families anymore, it's something we should just keep an eye on very, very closely, because we don't want to substitute these sorts of procedures or drugs for doing better as a society or addressing the needs of people, not only, and some of whom will get better, even the ones who won't necessarily get better, but at least to try as hard as possible. So you're giving me the body language.
Well, I've done this very. Move around and, or I can steps here. Look, did you see what I'm doing?
Let's try as hard as possible to what?
Try as possible, no, to be comfortable dealing with pain and suffering. Because what worries me about this is that, at least in those countries, people are coming in and they're saying, you know, that woman was like, my son doesn't talk to me, I don't see my grandchildren anymore, I don't want to go on, and instead of.
And he would like 10 minutes for her to grab the child off it, is that the same story?
Well, there are several of those stories, and it's just like, I think there's a need there, people are calling out and crying out, and either because there's not enough resources or we're not comfortable with it, saying that these people are suffering, and what can we do as a medical profession, as a society, to help them? They could, if we could get them better, they could live 10, 20, 30, 40 more years.
We want to make them live.
Well, we want to at least do everything. I would say we want to try everything we have in our arsenal to see what we can do before.
Your life, I just.
Okay, well,
Oh, I'm not saying they're just, using age line, that she's not, well, I don't want to be alive. Oh, no, I'm not saying they were, I'm not saying they are.
yes, it'll.
But if it did, and just as a primary care family interest, you would probably be one of those doctors all the time. I guess just personally, since having a dad that was able to make those decisions and welcome, families welcome that, would you be a physician that would participate?
I would, and again, people can draw the line. There's always an arbitrary. So I'm comfortable. I've never had a patient who's done physician-assisted dying, but I would be comfortable. I don't know if I'd be comfortable doing it. I haven't had, and I don't live in one of the states, but I'm comfortable enough with the system and process that it's not being abused that I'd be comfortable with that. But as actually administering something as a doctor would be so foreign to everything I would do that I was never conceivable. But even if there was a system in place, and that's what makes me worry about the doctors in Europe that seem to be comfortable doing this. Now they would argue back. I understand the counter arguments, but on a personal level, do no harm. Even you could intellectually argue that not doing it is doing harm. I understand the intellectual argument for me that would cross the line too much.
But the gerontologists are essentially all resource like that, correct? So lot of gerontologists,
Yes.
right?
Yeah.
So most gerontologists cannot have private practice, they work for
Yeah.
healthcare systems.
Right.
And the irony is that we have a burgeoning baby boom, we have an explosion of technology and pharmacological advances, which can keep people alive longer than perhaps they should be, and longer than equals the quality of their life. And where is the medical system coming in, dealing with that,
Right.
saying palliative care has to
Okay.
be huge.
Well,
We need
yes.
to address technology and medicine, and
Yes.
where do we?
Okay, it's captive. And I'm glad you said that, because, you know, I can't be more of an advocate of palliative care, which, you know, is very, it's not used enough, it's not funded enough, but in certain hospitals, in certain settings, there are in the inpatient setting, it's better. There are very vibrant palliative care services. And when they get called, and if they're good, and patients listen to them, and families listen, there can be remarkable things happen. And they can do house calls, and help, and they, by the way, they want to get involved. Don't call them 2 days before the person's gonna die. Then they're useless.
Right.
Well, some of it's reimbursed, it's starting to get reimbursed by insurance companies, and some of them are hospital staff members who can do this, right? So it's an overwhelmingly underused resource, and some of them are incredibly skilled, and they know the data about end-of-life interventions, most of which aren't very good, and they can tell them, and if they're good at it, they just get people thinking about it, because, you know, another thing that I think is important is if people have terminal diseases and you start talking about the trajectory of it, and this break, I get to mention the Oliver Sacks article, right? So I covered everything. Think about what Sacks started to write about. That piece was about 6 months before he died. He wasn't writing about going in a ventilator. He was writing about the realistic expectations of what could happen in the next remaining part of his life, and how he's going to spend those months in the most rich manners possible, right? And he was talking about technology. There's no medical interventions mentioned. It's all about reattaching with old friends, laughing, not watching stupid TV. You know, there's certain things that was eliminated. I forget what it was. Politics. That's the PBS comes out, right? So comes out, but he knew, I assume, that he wasn't going to go back in the hospital at the end. He didn't say that explicitly, but that's implied. And that he had an expectation. And to use stories like his as a way, you know, and engage palliative care people to sort of talk about this is the trajectory. There's always outliers. You know, there's some people, this and that, and we can keep the discussion open, but this is what most people in your situation expect. And to prepare us, because, you know, what we're so bad at is, you know, the person with cancer, and oncologists are sometimes the best at this and sometimes the worst. You know, they're still giving too much chemo at the end, and they haven't had the discussion, and then there's a crisis point, and there's really nothing more to do, and the person hasn't thought about it, and that's the last situation.
Some of them have, like my father, colon cancer, so catering surgeon, another 6 months, goes back. Don't tell. He's got to be much better. So for a number of months, my mother did, he knows best, he knows best. I happened to be in Washington Square Park. I run into a woman walking our dogs, and she says, what do you do? And she said, oh, I'm a social worker, so I'm petting. I said, oh, my dad was there this summer. She said, really, what's his name? I tell her. She says, oh, sure, I remember meeting your mom about hospice and talk. How is he doing? I said, he's doing great, but he still doesn't know yet because Dr. White keeps saying, she said, you know what? Dr. White can't talk that. She said, there are a number of his patients that died. So I was like, oh, that's it, you know, because I was fighting with my mom. And when I called her up, she said, I told that. And I said, thank God, because here's the story. But I mean, and here he is a surgeon.
Outrageous.
Yeah, outrageous.
Okay, folks, let my doctor go.
Great title.
Thank you.
Grab a little more of a bite to eat and also we have Peter Scott's All the Rest book. If you didn't get it last year, I know there's some new faces in the audience. Just pick one up here on the red table. And have fun with it. There's some great alumni stories from the past century.